Okay. Good morning, doctors. I'm Maria Hernandez, and today we're going to discuss about the management therapies for multiple sclerosis. First, okay, it's not working. Oh,
it's working
first
fine.
we need, yeah, no, but it wasn't moving. Okay. First, we need to know about the definition of the disease. This is a chronic and progressive immune-mediated disease that affects the myelin that is presented in the central nervous system. This is one of the leading causes of disability in young adults. It's important to notice about the, sorry, I need to put this, okay. It's important to notice about the epidemiology of this disease. This disease is more frequently presented in females than male. It is also presented more in rural areas than in urban areas than rural areas. The onset of this disease is usually in the mid-20s to early 30s, but we can see patients that are younger than this and they're older than this. Also, the disease is usually presented with autoimmune conditions. Some of them are psoriasis, another one is thyroid disease, and another one is diabetes type 1. This disease is also related to the levels of vitamin D in patients. As we can see, we're going to discuss a little bit more about that, and this is one of the new targets for treatment of patients with MS, and also have a genetic component and can be seen more frequently in patients that have a family history, but it's not the main component of this disease. This disease has been related to viral infections as a possible trigger for the autoimmune response, and the most common virus that can be related to this disease is Epstein-Barr virus. Also is seen in varicella zoster virus, and cytomegalovirus is supposed to be a protective factor. This disease is usually more common in patients that live far from the equator, and is more common in patients that are Caucasian, with the ancestry of European family. Some of the studies, they call this a Viking gene. The prevalence in worldwide is an estimated 2.5 million people that are affected from MS, and is, as I told you before, has a high prevalence in Northern Europe, North America, Australia, and New Zealand. I think that I read that Canada has the highest cases of MS, and has a low prevalence in part of Asia, Africa, and South America that is near to the equator. And these images, we can see the prevalence of MS in United States is nearly 1 million people in the United States that suffer from MS. The prevalence has been increasing over the past of the years, but is still more frequently seen in females than male. And this is the disposition of MS in the US map. This disease has a cause that is unknown as many autoimmune disease, but it is known that there is a genetic factor and also an environmental factor. Both of these factors cause an autoimmune response that can cause inflammation in the blood-brain barrier, and this allows to the T cells to arrive to the places where the oligodendrocytes are, and these cells are going to be activated. They're going to secrete cytokines, and these cytokines are going to affect the blood vessels in the CNS, and this is going to cause an increased number of B cells. These B cells are going to secrete antibodies, and these antibodies are going to be recognized by other cells such as microglia and macrophages, and these cells are going to eat the myelin that has the oligodendrocytes, causing the deposition of tissue in the sun that is this cell, and it's going to cause the deposition of plaque, those are the lesions that we're going to be seeing in the MRI. As the cell lost the myelin, also lost the conductory electrical conduction of impulses in the CNS, is going to be causing the symptoms in patients. And later in the progression of the disease, we're going to have increased numbers of T cell regulatory cells, and these cells are going to cause the increased process of myelin, and that is why the patient can have symptoms of relapse and symptoms of remission. And this is an imaging, as we can see, this is the immune response. Is related to activated T cells that are going to be in contact with the oligodendrocytes, and they're going to secrete cytokines. This disease has multiple clinical causes, but most of them are related to the relaxing remitting multiple sclerosis. This is usually seen in 85% of the patients. This is related to partially improvement or completely improvement that is also following by a recurrence. So it's going to be up and down, up and down. This can be inactive, active, or highly active. Other patients have another course that is primary progressive MS. That is when the patient has a late onset of the diagnosis, usually more than 40 years old, and this has a steady progression. Another one is a secondary progressive MS that has a steady progression. They usually have remitting and relaxing situations, but later they're going to be progressive and it's going to be steady. It's like an arrow. And another one is the progressive relapsing that is also steady, but with multiple attacks. These attacks are seen as a clinical episode when the patient have focal or multifocal inflammatory response, and this response occurs in the last 25 hours, and can be with recovery or without recovery, and this patient needs to be ruled out first in case of infections. The patient can have multiple clinical manifestations of MS, but this is a result of the plaque that I told you before that is going to be they have a deposition in the central nervous system. Usually one of the main symptoms that the patient can be presented is optic neuritis that is presented as a loss of vision and also pain with movement. The patient can also have ataxia, limb weakness, paresthesia, bilateral Babinski positive, loss of bladder function, cognitive dysfunction, sensory loss. There is a lot of clinical manifestation that can be seen in patients suffering from multiple sclerosis, and this disease can have some triggers. One of the most frequent triggers of this disease is heat, exercise, and fever. And when the trigger causes the clinical manifestation, we call this on-top manifestation. Also, we can have another signs of this disease, that is the Lermite sign, that is one of the most frequent ones, that is the sharp pain that is in the back of the neck and is moved to the lumbar side of the patient. And also can have the Charcot triad, that is when the patient is presented with intentional tremor, dysarthria, and also nystagmus. It's important to notice that one of the main factors that is related to this disease is smoking. So it's super important that we talk the patient to decrease the amount of cigarettes they're consuming per day or to avoid them at all. Also, it's related to fatigue and hyperventilation. One of the main criteria that we use in order to diagnose multiple sclerosis is the McDonald criteria. This is based in two issues. One of them is the clinical manifestation, that the patient have one or more than one attacks with focal or multifocal manifestation, and the patient needs to have more than one lesion in the MRI, that is the plaque that are deposited in the central nervous system. One of the main diagnostic tests that we use in order to diagnose MS is the CFF. Then we can see monoclonal pleocytosis, and also we can see the oligoclonal bounce, that is the most frequently seen in patients in 90% of the cases. But we need to make sure that this is not specific for MS only. We can also see this oligoclonal advance in other diseases such as, for example, Lyme disease. And the gold standard of this disease in order to diagnose MS is MRI. In the MRI, we're going to see the plaques that is the result of that immune response that are seen hyper intense, like wider in the MS in T2 and T2 flare. Here we can see the deposition of the plaque in the corpus callosum that is called dozen fingers. With the MRI, we can see when the patient is having an acute attack or this is a chronic disease. When there is acute, we see edema that is with hypointensity, and also when it's chronic, these lesions are going to be contracted. In T2, they're going to be hyperintense, where they're going to be united, like less than more space. And in some cases, when the progression of the disease is steady, we can see periventricular lesions that are going to be joined, and they can cause a mass effect, and they can be like a glioblastoma. Mm. Also, we can use another diagnosis test, such as bucket potential, that is going to be decreased because of the loss of myelin, and the optical coherence tomography. Then in that test, we're going to know about the layers of the eye to make sure that we're not losing myelin. The course of the disease is intermittent. Is going to be having phases of relaxation, phases and remitting. Usually in the 30% of the cases, the relapse is within the first year, and this is going to decrease as the years go by. But it's important to notice that if we don't treat the patient in the early phases of the disease, these patients are going to be dealing with disability in 7 to 10 years. So it's really important that once that we diagnose the patient, we need to treat them. After a few years of this disease, this is going to be a slow phase, and the lesions are going to be accumulating. It's important to notice also that in patients that occurs with MS and have pregnancy, this can be stabilized during pregnancy, or we can have clinical improvement. The average duration of the illness is 30 years, and the survival rate of these patients suffering from MS is slightly decreased from patients that don't suffer from this disease. It's usually 7.5 less years than patients that don't curse with this disease. There are some factors that are associated with the aggressive course of this disease. Some of them is when the patient is male gender, when the onset is older than 40 years, when they're African American, when they have frequent relapses, when they have new lesions of the MRI within the first year of the treatment, when they have low vitamin D levels, and they have multifocal involvement. Usually when they have more presentation in the spinal cord than in the cerebrum. We have multiple treatment options for the patient with MS. There are two main approaches. One of them is the escalating approach, is that when we use medication that has lower efficacy, and we do it like a ladder, step by step. We are moving to more moderate efficacy to higher efficacy of treatment. And this approach has lower side effects, but multiple studies have shown that this is not the best approach for patients with MS, because if we use this approach, we're going to have more disability in patients suffering from this. So it's better that we use a early, highly effective treatment, even though it's going to be causing more side effects, but it's going to be improving the attacks and also the progression of the disease. About the treatment options of MS, we have multiple treatments, and nowadays you're going to realize there are more than 2,000 clinical trials right now since 2000, and it's really improving. But all of them, they're going to be focusing in controlling the immune response that is affecting the patient with MS. So they're going to be immunomodulations, immunosuppression. Some of them are going to be selective. Another one, they're going to decrease the number of mature T cells and B cells. But this is important because they're going to be the ones that are going to improve the progression of the disease. In these images, you can see the progression of the new treatment with MS. The first one, we only use injectable treatments. Then we found in the mid 2010, they found another treatment options that are oral treatments. And nowadays, the ones that are highly effective is the infusion treatments. First, we need to make sure that these treatments are going to be dividing into different sections. The first one that we're going to talk about is the injectable options of the treatment. First, we need to know that glucocorticoids are used in MS, but only in an acute attack. For example, if the patient is presented with loss of vision, we can give them glucocorticoids, and this is going to improve the course of the disease. But this is not going to be used as a chronic administration of the treatment, because we know glucocorticoids have higher side effects, so it's not really good for patients that have an autoimmune disease. This is going to be used as an IV bolus of methylprednisolone along with an oral dose of prednisone. One of the main treatments that we use with multiple sclerosis in the past year, but we're still using it, is interferon. Interferon is going to be have some mechanism of action in the suppression of T cell activity. This is going to reduce the cytokines, and this is going to reduce also the antigen presentation, decreasing the immune response in patients with MS. This is going to be useful in patients that have the remitted relaxing disease, and this is going to cause a delay of 9 to 12 months of patients having attacks of MS. Usually the side effect of this treatment is flu-like illness and lymphopenia, so it's not a big deal. Another one that is used as an injectable is glatiramer. Glatiramer has an unknown mechanism of action, but some studies are finding that it might be related to the T-cell immunomodulation, and it makes sense because we are dealing with autoimmune disease. This is useful in patients that have clinically isolated symptoms, so the patients that they only have one attack and they don't have any relapses, and patients also with relapsing. The side effect of this treatment is injection site reactions. So we know that they have side effects, but the side effects are not that big. As we're going to continue with the treatment, we're going to notice that the side effects are going to increase, but also the new treatments are going to be more effective than the one that I told you before. About the oral therapy, we have multiple therapies. One of them is dimethyl fumarate. Dimethyl fumarate also have an unknown mechanism of action. We're going to be using it twice a day. This is useful in patients with the relaxing remitting MS, and also is going to be related with the immune system and the numbers of T cells. About the side effects of this treatment, usually flushing, gastrointestinal upset, lymphopenia, but one of them is a serious side effect, but it's not that frequently in this treatment, but we need to make sure that we control the patient, is PML, that is related to the JC virus. Another treatment that we use for multiple sclerosis is fingolimod. Fingolimod is going to affect the SP receptor analog, and this is going to interfere with the mature lymphocyte that is going to be in the lymph node. And the lymph node, they're going to arrive to the blood-brain barrier. So we're going to decrease the movement of this cell and decrease the immune response. This is usually successful in patients that have also the remitting relaxing MS. As well, this is going to be a delayed response of the attack for 9 to 12 months, and it's going to be also useful in decreasing the lesions that we see in the MRI. One of the main factors that is side effect that this treatment is going to cause in patients is bradycardia, macular edema, herpes virus, basal cell carcinoma, and PML as well. So we need to make sure that these patients have electrocardiogram before starting this treatment, is going to be seen by ophthalmologists to make sure that they don't have any macular edema, and also is useful to use a consultation with a dermatologist. This treatment, another treatment is teriflunomide. Teriflunomide is going to be affecting the DNA of the cell, so this is going to be useful also in patients with relaxing intermittent MS, and this is going to be causing also the lowering of the attacks and also reduce the lesions that we see in the MRI. This treatment can cause nausea, hair thinning, hypertension, and it's really important to notice that this, as this treatment is affecting DNA, it can be teratogenic. So we need to make sure that the patients are not expecting or they don't want to expect a baby, to make sure that they have control in this treatment. And another treatment is cladribine. Cladribine is an antimetabolite that is going to be causing the lower the amount of T cells and B cells in the blood-brain barrier. This is going to reduce the relapses and also reduce the lesions that we see in the MRI. And this is going to be administered in 2 courses of treatment over 2 years. The side effects of this treatment is herpes virus, zoster virus, infections, and rash. All of them that they have this orange ball, they're going to be controlled with a blood panel, with liver enzymes. They're going to be controlled with electrocardiogram in some cases. And also we need to make sure that the patients have, they're not going to be administering live vaccines while they're doing this treatment. Another treatment options for MS are the infusion therapies. These are the main ones. First, we are going to talk about alemtuzumab. Alemtuzumab is a monoclonal antibody that is related to the CD52 antigen that is presented in cells, B cells and T cells. This is going to be reducing the number of the cells, reducing the immune response, and this is going to be administered in 2 clinical courses. The first one, in the first year, you're going to be doing once a day for 5 days, and later in the second year, we're going to be using once a day, but only for 3 days. This treatment is related to an increased risk of infections such as herpes, varicella, and listeria, but it's also related to thyroid disorders and also immune thrombocytopenic purpura. So this is going to be also useful to make sure that we have the blood count and also we have the coagulation panel. Another treatment option for multiple sclerosis is mitoxantrone. Mitoxantrone is an antineoplastic agent that is going to be decreasing also the numbers of B cells, of T cells, and it's going to decrease the antigen presentation. This is useful in relaxing MS. This as a cumulative dose is usually used 3 months for 2 days, but it's really important to notice that this treatment is high. It has a high side effect that is cardiotoxicity. So we're not going to be using this treatment as frequently as the other ones. And also there is a risk for leukemia, myelosuppression, and alopecia. So we need to make sure that we are controlling the treatment. Another treatment option is another monoclonal antibody that is naloxone. Naloxone is one of the most effective treatments for MS. It's related to the alpha-4 integrin receptor antagonist. It's going to decrease the number of B cells, of T cells, and the migration of these cells into the blood vessels in the central nervous system. This is going to be useful in patients that have relaxing remittive NS. It's used once every 28 days. And we need to make sure that the patient is followed with the JC virus antibody, because this treatment, even though it's highly effective, is also related to an increased numbers of PML cases. I think it was 700 cases that have been diagnosed in patients that are treated with natalizumab. This treatment can be also related to infusion reactions, gastrointestinal upset, and acute retinal necrosis. So we need to make sure that we're following the patient with the blood test, with the ophthalmologist, and also with the antigen of JC virus. Another treatment option is another monoclonal antibody that is related with the CD20 that is presented in B cells, that is similar to rituximab, for example. The name of this treatment is ocrelizumab. Ocrelizumab is one of the most recent treatments that we use for MS. It's also useful in relaxing MS. This is important because, as you have noticed, most of the treatment that we use for MS is only for the relaxing remitting phase of this disease. But there are 3 of them that are not really, they don't have any treatment that is successful for them for the time. But now we have one of them that is ocrelizumab that is successful in patients that have primary progressive MS, so it's an improvement. They have 2 initial doses, one is 2 weeks apart, and later is every 6 months. One of the side effects of this treatment is infusion reactions, herpes virus infections, and we need to make sure that this patient doesn't receive live vaccines. Another new treatment for MS is siponimab. Siponimab is similar to fingolimab, but in this treatment, this is going to be more selective than the previous one. So, and also this treatment is also useful for patients that have secondary progressive MS and clinically isolated syndrome. The 2 main clinical trials when they decided to study siponimab is a BOLD trial. They find that there is a reduce of the lesions on the MRI, and the other trial is a SPAN trial that they reduce the disability progression for 3 months in patients, and they relax for more than 12 to 1 year of the attack. One of the side effects of this treatment is that is also cardiotoxic. They have cardiotoxicity, so we need to make sure that the patient doesn't have sinus bradycardia, AV node of MI in the recent 6 months before giving them the treatment. And another side effect is headache and hypertension. Also, this treatment is contraindicated in patients that have a certain cytochrome genotype. So we need to make sure that they don't have this phenotype in order to don't give them this treatment. This was approved by the FDA last year in March. And this year, they have another treatment that is ozanimod. Ozanimod is also related to the sphingolysine phosphate receptor. In clinical trials, they decided to prove the effectivity of this treatment with control and also with interferon. And they found that it's more effective than interferon in cases of relaxing and in the lesions that we see in the MRI. This treatment is usually well tolerated. I think that I read that with the coronavirus, it's approved, but it's not in the market yet. And another treatment that is no approved is lakinimab. Lakinimab is going to be decreasing the immune response, and also is going to have a reduction of the relapses in patients with MS. In these images, we can see the efficacy of the modulating treatment of MS. The first ones are the oldest one, and this has efficacy is moderate, but if we can compare with the new treatment, the efficacy of these treatments are higher than the other ones, and there is a really improvement in the lesions that we see in the MRI, so this is going to cause less symptoms for the patient and decrease the progression of the disease. As we see, one of the most successful approach for the treatment of MS is the early effective therapy. As I told you before, the ones that are highly effective is natalizumab, ocrelizumab, alemtuzumab, even though it has a really high risk of side effect, Susantrone is really effective. And the ones that are moderately effective are the oldest ones. They are usually the injectable ones that is interferon in glatiramer. We need to make sure that before starting the medication, we are going to monitor the patient with the MRI When we switch to another medication, we need to make sure that we also do the MRI and 6 months later, and then it's going to be once a year. What happens if the patient doesn't respond to the treatment? We need to make sure that that once the patient doesn't respond to the treatment, we have another option for the patient. If the patient has a failure with injectable, we have two choices. One of them is that we change it to the other class of the injectable, or that we use an oral treatment. And also is one of the options that the patient may have is that we use an infusion therapy. If the patient have an initial failure with natalizumab, that is a highly effective treatment, we need to make sure that change it not to a moderate one, but to a highly efficacious therapy, such as ocrelizumab, alemtuzumab, and siponimab. When the patient have a failure with oral agents, we need to make sure that to change it to an oral agent or change it to an injection one or an infusion one. Other options for treatment when the patient is refractory to the treatment is the use of, but it's going to be acute, no, it's going to be used in chronic phases. The use of glucocorticoids, IVIG, cyclophosphamide, and in some cases, multiple studies have been seen that they can use a stem cell transplantation in order to decrease the numbers of attacks in patients with MS. These treatments that I told you before, I know there are a lot of them, but most of them, they're going to cause the reduction of the attacks in patients and also the reduction of the progression of the disease. But this is not going to be affecting the symptoms that the patient are having. So we have also a specific therapy in patients that are suffering from MS. With fatigue, we use multiple treatments, amantadine, dextroamphetamine, modafinil. In patients with depression, there is not a gold therapy for patients that are presented with depression in multiple sclerosis that is highly frequently. Is 20 per 40% of the patients when they are diagnosed with multiple sclerosis can deal with depression. There is not a specific one, but we usually use SSRI. There are also treatment for GAID, for blood disorders, we use betamethasone, oxybutynin. With spasticity, we can use baclofen. And with the tremor, in case that there is unilateral, we can use surgery or we can use isoniazid. The cost of the annual treatment for MS is going to be $70,000 per year. So it's really expensive. And I read that is the four main disease that is going to be more expensive for medical therapy in the United States. We need to make sure that the patient have expectation to therapy. This is not going to be right away. They're not going to be having a clinical improvement in a few days, but in the course of time with treatment, they can deal with the disabilities, they're going to decrease them, and they're going to be having a more successful life. And this is a summary of the treatment that we can use. As I told you before, most of them are useful in patients that have, of course, with relapsing remitting disease. And the progressive ones, they don't have a lot of treatment, but the new therapies that are developing in clinical trials, they're going to be more effective to this type of MS. As I told you before, as this treatment, they're going to affect the immune system, it's really important to notice that these patients are contraindicated to use lipocine of them, but they can use a kill vaccine that they're not going to be a risk for them. And they need to receive also the flu vaccine every year. We need to make sure that we test the patient for TB and hepatitis B before giving them some of the treatment, and to separate the use of the vaccine with the new treatment that we are going to be using. There, as I told you before, there are a lot of clinical trials of MS, so it's really hope for in the future for patients to decrease the numbers of attacks and also decrease the progression of the disease. There's a lot of them, I try to make a summary of the most successful one. With the new targets of clinical trials, we have 4 main targets. One of them is a B cell targeting that is with tyrosine kinase. They're going to reduce cell proliferation. They're going to reduce survival and migration. One of them is in phase 2, that's about AMIQT, that is a reduction of the lesions and also the relaxes of the patient. And one of them is in phase 3, that is AMIQT. Then this treatment is really important because this treatment is going to be useful in patients that have progressive course of the disease, primary and also secondary progressive. Another treatment option is the treatment that increases the numbers of oligodendrocytes that has myelin. They're using animal models with different treatments such as benztropine, miconazole, and clobetasol. Most of them are in phase 2. Another one is apixanomab that is going to be also related with the increased numbers of cells that have myelin. And another one is enasanumab. I'm sorry, but the names are really difficult to pronounce. This is going to decrease affect the cells that is related with decreased axonal growth, so it's going to be related with the myelin. And another one is the immune dysregulation, so they're using stem cell transplantation and also mesenchymal cell therapy. Another treatment is Ibodilax, that is, I think, is in phase 2 of clinical trials, that is going to reduce brain atrophy. As the disease goes by the years, the patients they have multiple lesions, so these lesions are going to be causing brain atrophy. So this is one of the main therapies that are going to be focuses on this phase of the disease. And another treatment, as I told you before, vitamin D levels are really related to the progression of MS. So the nowadays clinical trials are using vitamin D as a therapy for improve the symptoms of MS. Also, they're using simvastatin. All of them are in phase 3, and lipoic acid. This is a summary of the new treatment. Most of them are in phase 2 clinical trial, and all another ones that are in phase 3, but they are developing. Maybe in 2 or 3 years, they're going to be in the market. As I'm going to be concluding this presentation, there is one news that was from last week that in the Rochester University, they found that when they use human cells in rats that they suffering from MS, they found that there is increased numbers of cells with myelin. They're going to improve the conduction, and they are also going to improve the symptoms. So this is a really great news for patients that have MS, because they're going to be related to the repair of the damage, and this may be useful in patients to restore the cognitive function. That is one of the main clinical symptoms that is really hard to improve in the patients. And this therapy is not only possible for patients with MS, but also for other neurodegenerative diseases. As a summary, the multiple sclerosis is one of the major causes of physical disability in young adults. This is going to be having more implications in connection, emotional well-being, and the life of the patient employment. Without therapy, most of the patients are going to develop disability over 6 to 10 years. So it's really important to use right away when we diagnose a patient with MS with medication that is highly effective, also along with physical therapy and cognitive rehabilitation therapy. And as you have seen, there are multiple clinical trials ongoing, and they're going to be focusing on new therapy for patients with MS. Thank you for your attention. If you have any questions, just let me know. I will be happy to answer them.
Thank you. What a wonderful presentation. Incredible. It's amazing you can pronounce all the names of these new medications. They're mouthfuls, as you say.
Thank you, Dr. Hernandez. That was a great presentation.
Thank you. It was a long one, but.
Oh, it's amazing. You did a lot of work to understand this.
Yeah.
Peter, how do you feel about this
The
presentation?
MS, were you able to tape it?
Yes.
Yeah, good, good. So we'll have a chance to look at it too.
Okay.
Maybe on the weekend, if you can send me the tape on the weekend.
I will do that. It's a fantastic presentation.
Yeah, we've gotten so busy here.
Okay. Thank you
with,
so much.
Cervical radiculopathy and everything.
Okay.
Well, thank you very much. It was a wonderful rotation. I appreciate it.